Welcome to Pulmonology Read Aloud. This is Dr. Ansham Aneja Arora back with one more video. First of all, before I start with this video, a heartfelt thanks to all of you who've met me over the last few months in conferences, in seminars, and praised my content and encouraged me to keep making more content and doing better. So this one is in continuation with my OSA series, and I did one video on the pathophysiologic mechanisms of OSA. And when I was doing this video, I discussed about the endotypes. Now, endotypes is something which is very interesting because you start realizing that all of OSA is not upper airway obstruction. And because I really had a good interest in that topic, I thought, let me delve into it further. And so I came across what is called as the PALM classification of OSA. So there is a short reel on the basics of PALM classification that you can go and see in the video links, but here it is in detail. So let's get started with it. Now, the PALM classification for OSA was defined not recently, but sometimes back. So it's not a very recent paper, but this is the first description of this entity, which was in AJRCCM by Danny Eckert et al. And in this paper, they have classified the endotypes. They've talked about the peak rate, the arousal threshold, and how it was estimated in physiological studies. So, what does the PALM stand for? PALM or P stands for the critical pressure, right? The pressure at which the airway will get closed. That means the anatomic collapsibility. So, this is the component or this is the type where anatomy or anatomical obstruction or collapsibility is causing obstructive sleep apnea. So, anatomic obstruction can happen because of one, deposition of fat in the upper airways and also in the abdomen. So, in obese patients with a lot of abdominal obesity, there could be a reduced lung volume, there could be a extra thoracic pressure, and that can also result in some level of obstruction. In this endotype, the patients will present with snoring and repeated pharyngeal depression. So they will have obstructive events, the typical sleep apnea with snoring. And whenever this keeps on happening repeatedly, the pharyngeal collapsibility occurs, then it leads to a chronic inflammation in the soft tissue. And this will reduce the diameter of the upper airway and further increase the airway collapsibility. We know that this typically happens more in supine position, and also a lot of times positional obstructive sleep apnea may be seen in this group of patients where supine position will worsen the sleep apnea. It can further be enhanced by a drop of the tongue or occlusion of the airway by the tongue and also by the backdrop of the jaw. Now, when we talk about this pressure at which the airway is closing, the critical pressure, it cannot be routinely measured. It can be assessed in physiological studies during a CPAP trial, wherein you can reduce the CPAP levels and determine that pressure at which the upper airway occludes. In some of the few slides, as I go ahead with this talk, I will be showing you how it has been demonstrated. The second of the palm is the arousal threshold. Now, arousal threshold or A is the level of inspiratory effort at which obstructed events will terminate and the patient will arouse from sleep. So, this is that level where now there is an arousal. And this group of patients where the threshold required to achieve the upper airway opening, and to get a good sustainable ventilation, that threshold is called as the threshold of effective recruitment, or TR. That means that threshold where the airway will open up. And that arousal at the end of the obstructive event, which occurs when this arousal threshold is less than the threshold for effective recruitment. So let me just reframe it for proper understanding. Now, if the arousal threshold of the patient is lesser than the effective recruitment arousal, the patient will get aroused earlier. And if this patient gets aroused earlier, there will be an instability in ventilation, and this patient will also have a lot of sleep disturbance. Also, in certain patients, when hyperventilation starts following upper airway reopening, then also you may see it to be altered because there's a stimulation of arousal center. So, arousal threshold can be the second mechanism in which a patient may be having more sleep fragmentation. So, patients with low arousal threshold will have more sleep fragmentation. They will have more ventilatory and pharyngeal instability, pharyngeal muscular instability. So next time the obstructive event will have more tendency to recur. And this is also typically those patients who have more daytime sleepiness because of a fragmented sleep at night. So this is the second phenotype of the patient where all the mechanisms successfully achieve the upper airway patency and a sustainable ventilation, but the arousals are too frequent. So a patient with low arousal threshold is the other type. Coming to the L of the palm classification, the loop gain. Now, this refers to ventilatory control, that is the central control, but it also has three components. The loop gain can have a control component via the chemoreceptors. It can have an exchange component via the lungs, and it can have a connection component via the blood circulation. Now, essentially, it revolves around partial pressures of carbon dioxide and how the ventilatory control happens in response to it. So, either that can be affected because of the chemoreceptors or through the exchange in carbon dioxide at the lung levels or through blood circulation. So the mechanism of loop gain or loop control is that there could be a control gain or a plant gain. Now, what does that mean? A control gain is the degree of response that the respiratory system shows to any change in PaCO2. Now, if the respiratory system is too sensitive to changes in PaCO2, patient will again have a lot of instability in breathing. What is plant gain? It means the ability of the respiratory system to respond to the reduction in carbon dioxide by ventilation. So, that is the gain in terms of how the ventilation will be changed when there is a reduction in CO2. So, a control gain, the degree of response, and the plant gain, ability of response. If the patient has a high loop gain, a high control gain, that means the degree of response is very, very high to changes in PSO2, then it's a very hypersensitive system in that patient. He is having a lot of ventilatory response. So he may have something like a periodic breathing, a chain Stokes respiration. If the patient's loop gain, that is the response that the patient's respiratory system shows to the PaCO2 changes, then it will be a more stable respiratory system. Now, currently, the reference methods of assessing loop gain also require specialized physiology lab. So, you and me cannot really assess the loop gain in our routine PSGs that we are seeing because it will need carbon dioxide, so it will need hypoxic, and hypergapnic gas administration or a manipulation in CPAP. There have been attempts to find out whether a patient's loop gain is at fault also by doing a lot of other maneuvers, such as one maneuver which has been described as the breath holding maneuver. And they defined it as a very cost effective and easy daytime test to see whether a OSA patient has a higher loop gain. However, we haven't been able to really incorporate it in routine PSGs. The M of the endotype is muscular upper airway gain. And I've discussed all of this at the basic level in my previous video in pathophysiology. So I'm trying to keep it a little more advanced to it. So in case you're not understanding the concepts here, you are welcome to see that video first and come back to this one. So the muscular gain or the upper airway gain. Now here, whenever there is an obstruction and following that, we see that out of all the upper airway muscles, the genioglossus muscle is the one that is most important in maintaining the upper airway patency. There are other muscles that regulate the position of, say, the hyoid bone, the geniohyoid, the sternohyoid, but there are pharyngeal constrictors also. There's also tensor belli palatini and elevator palatini. But of all of this, the muscle at the base of the tongue, the genioglossus, is the main dilator of the upper airway. So it has very important function which will keep the tongue protruded and depressed so that it doesn't block the upper airway. So in muscular gain, mainly we can assess the genioglossus muscle. We would want to see if the muscle is achieving hypotonia during sleep. Because if this muscle's activity can be increased and the hypotonia can be prevented, then in this group of patients, OSA treatment will involve the management of this muscle. And one of the forms of this is the newer hypoglossal nerve stimulation as a treatment. So, in this endotype, the muscle is the one which is at fault for causing sleep apnea. And if you stimulate the muscle, if you increase the activity of the muscle, then you can achieve it. Now, how can we assess this? Again, you may ask. So, if you do a conventional EMG with needles, in the genioglossus, that's the traditional method for identifying hypotonic patients, but it is invasive and it's very impractical for using in our clinical environment. There have been attempts by doing a transmembranous EMG. There have also been certain instruments like the Iowa Oral Performance Instrument, IOPI, the Tongue Digital Spoon, TDS, and most importantly, or most commonly, there have been orofacial myofunctional evaluation, OMS scores, and the OMS protocols that can be done to have a non-invasive method to identify the M component. And these are non-invasive methods, and you can measure this muscle potential over time. But again, if you ask me, is it done routinely? No, probably in a specialized physiology lab, we can do these. Now, if we know all the elements of the palm, the pharyngeal collapsibility, the arousal threshold, the loop gain, and the muscle, then it's important to understand that 20% of our OSA patients will have anatomical factors, but 80% of OSA patients will have both anatomic plus either an anomaly in arousal threshold or a loop gain or muscle responsiveness. And so, if you're just treating the anatomic factor, you may not achieve a good control of OSA in these patients, and it's very important to stay mindful of this. Now, one note about the genioglossus muscle. Now, I said the genioglossus muscle is responsible for upper airway patency, and the hypoglossal nerve is the one that stimulates this muscle. And so, by hypoglossal nerve stimulation, which is a newer method, we can decrease the activity or our hypotonia of this muscle. We can increase this muscle's activity in inspiration, decrease its activity in expiration, and by increasing this activity, we can prevent hypotonia. So, this is the basis of hypoglossal nerve stimulation. Now, this is a summary of the OSA clinical phenotypes and the phenotypes which will benefit from various pharmacological approaches. Now, if you look at these phenotypes, you can define these phenotypes as the classic OSA, which is this group A, the patients who are B, which is oldest and very comorbid patients, female OSA patients or patients with insomnia and comorbid, D, youngest upper airway symptoms, E, the ones with severe hypoxemia, and F, the severe non hypoxemic variant. If you look at this, the classic patient, young, obese, with excessive daytime sleepiness, with features of high AHI and a medium reduction in oxygen saturation, so an ODI which is positive, these will be the ones which will benefit with CPAP. And these are the ones which have a highest risk of cardiovascular disease. If we talk about the old patients, the comorbids, they may have obesity, they may complain of EDS, or they may just complain of NAPS. There also you may see a high AHI, and you may see that they also have an oxygen desaturation index which may be high. They have a lot of comorbidities, and they may not benefit as much with CPAP as the classic young ones do because they have other comorbidities also. The group C, the insomnics, the comorbids, and the female patients in the middle age who are overweight and obese may also have symptoms of insomnia, may also have a high HI with oxygen desaturation, with or without comorbidities, and they may also have only a medium benefit with CPAP. The young patients with upper airway symptoms, which are the youngest non obese patients, may have symptoms of choking while breathing, sleeping, and insomnia with very high HI. And they may have 10 to 15% time spent with low saturation because, again, their tone is good, so they still can prevent too much of hypoxia. They will also have a medium benefit with CPAP. Patients who are severely hypoxemic but are young, severely obese with excessive daytime sleepiness, they will have a hyper severe AHI. They may have 20 to 45% decrease in oxygen saturation in their sleep, and they will not have comorbidities. But because they have severe obesity and excessive daytime sleepiness, they will have a very good benefit of CPAP. There may also be a subset of people who are older obese. They will be less sleepy. They would say that we don't feel sleepy in the day. We are just like this, going about our work. But they will have a high HI with an oxygen desaturation, and they will also have a medium benefit. So, this basically tells you that the benefit of CPAP is not the same across all the age groups, across all the various phenotypes. And mind you, these are not the only phenotypes there. So if we talk about those phenotypes who are likely to benefit from pharmacological approaches targeting arousals, targeting loop gain and upper airway muscles, then this group who respond less to CPAP, the medium group, the females, the insomnics, the ones with upper airway symptoms, but no obesity, will also be the ones where pharmacological therapy can be tried. Coming to PALM 1, PALM 2, and PALM 3. So, based on these classifications, PALM 1 constitutes 23% of OSA patients, the upper airway types, very high upper airway collapsibility, a critical pressure of more than 2.5. Here, the treatment should be weight loss. They could use CPAP, they could use upper airway surgeries and mandibular advancement devices. So, basically, the anatomical treatment. The palm 2 constitutes 57% of our OSAs. They have an intermediate collapsibility. The critical pressure is between 2.5 to minus 2.5. And here you can subdivide them to 2A and 2B. 2A do not have major non-anatomical impairment, so they are purely anatomical treatment. But 2B will also have non-anatomical problems, so you need a combination treatment. Palm 3, 19%. Low upper airway collapsibility, the critical pressure is less than 2.5, with a therapeutic level of CPAP less than 8. Here you need a non-CPAP treatment option because it's not the airway collapsibility that's troubling them. You may have to give do weight loss, mandibular advancement devices, and in case the loop gain or arousal threshold is involved, you need to target that. This is one example of how uh, all of these pathophysiological mechanisms are studied in a lab in a PSG with physiological testing. And here, if you look at the EEG, so I'll try to briefly tell you how it happens. So, this is the EEG of a non REM sleep in this patient. You are looking at an airflow which is initially normal, and then the patient is having a reduction in airflow which continues, followed by an arousal threshold. Here, the patient is having back to eucapnic ventilation. How are we estimating the arousal threshold? Through the pressure. Now, you look at this in normal ventilation, the pressures are stable and then they reduce the CPAP pressure. So, when you reduce the CPAP pressure, this patient is having a kind of a hypopneic situation, and then there will be a point where the muscle responsiveness increases gradually and the muscles will become tightened. There will be an arousal, and at this point the ventilation will go up once the pressure is high. So, what they do in the lab is they slowly or abruptly reduce the CPAP pressure in a patient who's using CPAP. So, they say that when you are giving CPAP, then the volumes are okay, the patient's flow is fine. When you drop, you wait for that time when the patient will have an arousal threshold, and so you can estimate the arousal threshold of the patient. You can also estimate the loop gain because here the minute ventilation drops and then the minute ventilation will pick up. And so there are formulas through which you can establish what is the loop gain of such a patient. A little complex, but basically, the point here is that it is to be tested in a lab where the CPAP will be gradually reduced or stepped up. So this is how they do it. This is a revision of this original technique where the CPAP will be reduced every 1 minute until arousal occurs. Once arousal occurs, they will wait for to see if this arousal recurs, and then they will increase the pressure. If they don't see arousal, they will further drop the CPAP, and then they will keep decreasing the CPAP to find when the patient gets an arousal. So this is how they do it. This is the optimum CPAP. There is a good pressure here. The flow is good. The PCO2 is fine. They drop it to 0 and the PCO2 rises here. The tidal volumes reduce, the flow reduces, the saturation reduces. Now here they are giving a minimal tolerable CPAP. They drop it. You see how the PCO2 is rising, and then at a point it comes where the flow will improve and then the PCO2 starts normalizing. So to conclude, the PALM classification is good way to assess the endotypes of OSA, and it's a good reminder that all OSAs are not obstructive. This is a very good chart which summarizes the PALM classification, and you may take a screenshot of it for better understanding. See you again with another topic, and I am in the OSA series, so please let me know if there's something else that you would want to know. Thank you for subscribing and happy reading.